Dr. Henry, a lot of the restrictions that have been put in place are based on the science applied to Delta. And I know things have evolved with Omicron, but one of the outstanding ones has been an impact on events like weddings. The industry is frustrated with this. I'm just wondering what in the science shows you that a hockey game at Rogers Arena with 9,000 people and people cheering and in large cases people without masks on, how is that a safer environment than someone hosting a wedding event?
Yeah, there's always this, how come it's safer to go to Walmart when there's a bunch of people there, and how come it is all about looking at the risk setting, what you're doing in that setting. And I presented that a couple of weeks ago, the whole variety of things that we look at when we were talking about gyms, for example. So we do know that no matter what, it's those group settings when we're coming together, when we are with people that we care about, and weddings are a perfect example. And I just want to clarify, weddings and funeral services are not restricted. It is the celebrations, the parties afterwards. And we know that invariably those are the settings that we are seeing transmission. Not at every single one, clearly, but at many, many, many. And that was what, it's very challenging. And we've all been to wonderful weddings where, yes, you all start off with the right intentions and we're sitting at tables, but you're with people you haven't seen. It's a positive, joyful time. And so at the end of the evening where, it becomes more of a celebration, which is a wonderful thing, but also very risky right now. So yes, there are measures that we have in place that address in a sort of sequential way the highest risk settings, and then we put in mitigation things in lower risk settings. And so we look at a hockey arena. It's a much larger space. There's lots of ventilation. There's space around people with the small numbers of people that are allowed in with the capacity limits, the vaccine card. And yes, we do know that some people, but when you're at a seat with very small number of people around you and a large amount of space, it's much less risky than when you're in a nightclub or an indoor venue where you're closely with people without a mask on. So it is a gradation of risk, and we all know that there's some settings that we are seeing a lot of transmission, and there's some of the very same thing where we don't see any at all. So it is based on risk. That has not changed. The factors that we're seeing have not changed. It's indoor spaces with poor ventilation, less space, where people are not as likely to wear their mask consistently. Those are places where we see transmission. And as we have more and more transmissible strains of the virus, those become less and less able to or more and more risky depending on the setting.
Richard, do you have a follow-up?
We are seeing situations where pharmacies and other places are selling rapid tests. And as you are aware, there is a high demand for these tests. And in some cases, the price of those tests have escalated quite quickly. Just one anecdotal piece of evidence that was brought forward to us was a place was selling 5 tests for $100. A week later, it was 5 tests for $150. What do you think about this sort of price gouging for accessing rapid tests? And also to the announcement you made today extending the vaccine card, can you explain to us the science behind extending it all the way until the end of June?
Yeah, so I can't talk about pricing of rapid tests on the private market. I will tell you that there's a global shortage of rapid tests. We look to our neighbors to the south where they've been trying to get large numbers. It affects the amounts that we've been getting from Canada, so I expect that has something to do with it as well. We will and will continue to make rapid tests available in those settings where they are most useful first. And if and when we get to that place where there is an unlimited supply, my aim is to make sure that everybody has access to them as much as possible. In terms of the vaccine card, it has been very effective. Again, it does not eliminate the risk, but we do know and we continue to see that if you're not vaccinated, your personal risk has gone up dramatically with Omicron, with the amount of virus that's circulating, but also your risk of passing it on to others has gone up. So we still see that if people who are fully vaccinated, that mitigates that risk of both getting infected yourself and passing it on to others. And, doing that symptom screen, making sure we're feeling well, that we're vaccinated, that we have all of those other measures in place. It's one tool that allows us to have err on the side of having people in watching the hockey game or in restaurants. And it doesn't eliminate the risk, but it absolutely has been mitigating the risk. And I know it's been used quite effectively by many, many people in many settings. And what I said is we're expanding the program. When we put it in place in August, we were looking at the wave that we were dealing with at the time. And Omicron, of course, has meant that it's extended and changed once again. So it is important right now. I've said till the end of June, but as I've also said, we'll be reevaluating as we go through this next few weeks, and as hopefully we will see a decrease in hospitalizations. We'll see a decrease in the circulation of this virus in our communities, and we'll be reassessing on a regular basis the need for all of the measures that we have in place. Minister, I don't know if you want to add to that.
I think, Richard, as you know, from January 25th to the middle of February, we expect to receive 10,800,000 rapid tests, and they'll be distributed in the way that we laid out on December 21st and provided details as they come, and we'll be providing details to you as to how they're being provided around BC. Why are we giving priority to long-term care and to acute care and to schools and to certain businesses and congregate settings and so on? Why are we giving priority? Because even though 10,800,000 is a lot of rapid tests, it's in fact about 2 per British Columbian, and we have to focus on those areas where they can be most effectively used, and that's what we're planning to do, and that's what we'll continue to do, and we'll continue to provide detailed briefings as to how those are taking place. Obviously, no one wants to see anybody gouged, and that's something to look at. It's outside of the healthcare system. It's something we don't want anyone to look. We'll obviously be looking at, but this is the supply we're getting, and it's significant, and we have to use it most effectively. I think people would expect us to, and that's why we've laid out a detailed plan to do that, and we're following that plan assiduously.
Next question, we go to Rob Shaw, Check News.
Now that you're extending the vaccine passport, I know you've been asked this in the past, but do you have any plans to include the third booster dose as qualifying for fully vaccinated in the next 6 months, assuming that you keep the passport in place until the end of June?
Yeah, so I consider the vaccine passport is the federal card program, but the BC vaccine card that's in place for the limited number of venues here. I don't expect to add a booster dose as being part of it for a number of reasons. One is not everybody has yet eligible or has the opportunity to receive their booster dose, and there's still a large proportion of people, although that's getting less and less by the day, who've not received their booster dose and are not yet been eligible for it. So it wouldn't make sense to make it a requirement when a proportion of people just are not able to get it yet. And it is much more important for us to make sure that we have that 6-month interval, because we'll get through this wave. I have confidence in that, but we don't know what's coming next. So we want to make sure we're giving the best, strongest protection that we can for the future. And I'm hopeful that we'll be in a different place before June, and that will help us understand what's needed in terms of the BC vaccine card. But again, we'll be reevaluating this on an ongoing basis. And my philosophy, our philosophy, and my team in coming up with the measures that we believe need to be in place is about the least restrictive means, the least we need to do to make sure we're finding that balance of keeping things open as safely as possible and preventing our healthcare system from getting strained even more than it is right now.
Rob, do you have a follow-up?
Sure, thanks. Could you tell us a bit about what the safety risk difference is between youth and adult sports tournaments that One is in the case of children being allowed to start operating again next week, and the other stays closed. Why are they different, and what's the different risk?
Well, it is a little bit to do with risk, and it has a little bit to do with benefit. So part of it is we know that adult tournaments at this time of the year tend to be a very important social event, and that is, of course, a riskier situation. And part of it is, adults have the opportunities to do that on an ongoing basis, and there have been provisions, for example, for some of the high-impact sports and Olympic qualifying, etc. But we know that sports has a different place for youth in terms of growth and development and future opportunities. So we have always prioritized making sure that young people are able to access that part of these important aspects in their lives, particularly at that age, and that there are timing limits for things like university scholarships that become important. So we've taken all that into effect and prioritized really making sure that we can safely restart youth sports tournaments first.
Our next question goes to Graham Wood, Glacier Media.
Oh, hi, Dr. Henry. Can you walk me through the initial reasons as to why you didn't include masks for kids K to 3, and what your findings have been since then in terms of the effectiveness of masks for the 3 kids?
Yeah, so, our thinking about masks globally has evolved over time. The comfort level, I think, in all of us in wearing masks and where we need to wear them and what type of masks and what things work better. And partly it's talking with young people in my life and understanding that they can adapt and that they're fine with it. So we have, as you know, updated our protocols in schools based on what we were seeing in those schools, based on what we were seeing as being more and more important over time. I think the other thing that's really important over time is that the virus has changed, and I've said this before, when you have more of it circulating and it's more infectious, each layer becomes more important. So as we were moving into more infectious strains and having those outbreaks, it became more important to have that extra barrier in place for younger students as well. It's really challenging to tease apart. Is it the mask that made the difference, or was it because we changed seating or because we changed cohorts? So it's very difficult to understand what proportion of the risk was attributable to wearing masks or not wearing masks. It really is an overall function of all of the different pieces that need to be in place. And as the virus changes and is more infectious, or we have more of it in the community, having every single layer becomes more important. So I know that's not exactly the answer that you want, but those are some of the considerations that have gone into it. I will say as well that we look very carefully at all of the data that we see around the world around benefits and harms of every measure, and the one thing that is clear is that there are very little harms from mask wearing in those settings, and children can adapt to it. We've seen that very clearly.
Graham, do you have a follow-up?
Obviously there's a lot to this, but in terms of the harm, you're saying there's no harm. I'm finding that it may not be studied enough in terms of the social, emotional, the hearing, the speech, the audiology, the ramifications of masking, and how long do you think that this can continue for? If these kids aren't going to be provided respirators per se.
Okay, you've got a whole bunch of things packed in there, but obviously, as I've said all along, we want to do the least restrictive means, the least possible. So I think as we move through this wave, it's really important that we take all of those protective measures. We see this strain of the virus transmitting really rapidly between people. I don't believe, and I don't think there's anything that shows that in the community setting, particularly for children, that wearing a respirator, so an N95 that's not fit tested, gives any additional protection in the settings that we're talking about where there are multiple things in place than a well-fitting, comfortable mask that a child will wear. So those are the things that we try and balance. I hope and expect that as we get through this wave, and I've said I expect that we'll have a gentler summer. Having said that, this virus is changing and it's spreading very rapidly in many countries around the world. So we don't know what the next strain is going to be like, whether it'll be milder or more severe, whether it'll be more or less transmissible, able to evade the vaccine or previous infections. So those are all unknowns. But I do expect, and from history, that we'll see different patterns over time, and that it should, as we have more and more immunity, that will protect us globally from having more severe strains emerge. But there will be times, I believe, in the future where mask wearing in indoor public places will be important again as a way of trying to reduce our risk of spreading it to others, more so than contracting it ourselves. And it'll be one of those things that we do during that winter respiratory season.
Next question, Binder Sajan, CTV.
Hi there. I'm just wondering if there's an update on the field hospital, whether some space has been acquired, and given what we're seeing with cases and hospitalizations, it's sort of unclear to me if any hospitals in the Lower Mainland seem to be on the brink, and whether that field hospital would be required, and even if there would be enough staff to staff it if needed.
That's over to you, Minister.
Next, Binder, we have, as you know, 9,229 base acute care beds. We have 2,353 surge beds in our system for a total of 11,582. And currently in hospital, our census in hospital as of end of day yesterday in any event was about 9,050. In other words, under the 9,229 number. Now, that doesn't mean things are easy. In fact, we frequently in pre-COVID times would run well above that number. In the number we often talk about in January of 2020, we were at about 103.5% of capacity, about 9,500 beds at that time prior to COVID-19. The challenge now is, as I've described, that there are a number of healthcare workers off sick, and we have just under 1,000 people hospitalized with COVID-19 in BC. So we're making adjustments accordingly, according both to the staff complement we have and to our capacity complement. But what that tells you is it's not a field hospital in need. We need to continue to support our staff should they get sick to be able to come back, to get well and come back, and to support those in our healthcare system. So with that many beds, surge beds in our existing hospital, it's not the beds or the space, it's the people that is the most significant thing. So yes, we have space for field hospitals, should that be required. But that is an unlikely possibility. But we did that in April of 2020, and we've done that again recently to ensure that that's there if required. But we are far from that. That's not the issue in our healthcare system right now. The issue, as ever, is people and being able to provide the services we need and be able to get back as soon as possible to delivering the surgeries for all those who've had their surgeries postponed so that they can get on with their lives. That is critical to us. So I don't think the short answer is yes, the field hospital is there. But right now the challenge isn't additional beds in addition to the 11,500 plus beds that we have base and surge. It's ensuring that we have enough staff there to take care of the people in hospital. And yet, as of yesterday, that was about 175 under base bed capacity, or 9,050.
Binder, do you have a follow-up?
I do. Just wanted to ask about kids aged 5 to 11 and vaccination rates. I've seen in some places, like some provinces seem to have much higher rates. How big an impact do you think this NACI strengthening its recommendation will have on those vaccination rates? Or do you think there's just, maybe people are just not quite sure if this is the right move for their child at this point, and perhaps that will lag behind because, as you say, the risk isn't necessarily as high as it is for other age groups?
There's a couple of things. I looked with awe to Newfoundland and Labrador, and my colleague Janice Fitzgerald there, we were talking actually earlier today, where they traditionally have very high rates of vaccination, and kids there have been vaccinated in communities all around Newfoundland and Labrador. So, we could learn from how they do it, but I think there's a combination of things. I was a bit disappointed when NACI first came out and the language wasn't that strong. And the things that we learn about from NACI are, their guidance is directed towards healthcare providers, and there's nuance in there. And sometimes that can lead people to think that it means it's not recommended, which is not the case. And I think they made that very clear in their statement today, that they look at the situation that they were in when the decision was being made, how much we knew, and the fact that at that time we weren't seeing but a lot of transmission in our communities. Clearly that has changed with Omicron, and they make reference to that, where we are now seeing that young people are being infected. And yes, the rate of serious illness and hospitalization is still very low in that age group, thankfully, but more and more numbers of children are ending up in hospital. We're seeing that here as well. And we know that that kids can get really sick with this. Even if they aren't hospitalized, it can knock them out, and it's not an innocuous illness, as I've said. So we don't want kids to get sick. The other thing that vaccination, and this is not what NACI looks at. They look at safety and effectiveness and how it should be used. But the other important things that we all have is it allows kids to more easily and safely get back to all of those activities that are so important. And when I talk to young people in my life in that age group, it's important for them to be part of protecting their grandparents and older people in their lives, or making sure that they don't carry that anxiety of bringing it home to a parent who's going through treatments or is on medication. So I think there's a whole variety of things that make it really important for us to offer this protection to children. And I think I'm just happy that NACI has come out and said that it is an important thing, particularly now with what we're seeing.
Next question, we go to Derek Penner, Vancouver Sun.
Hi, yeah. You've been reporting on deaths due to COVID since the beginning of the pandemic. At this point, how concerned are you that the deaths that you're reporting might not be capturing all the deaths that might be attributable to COVID-19, considering the Statistics Canada data on excess deaths estimates?
Yeah, and we've also looked at excess deaths here in British Columbia, and my team has been analyzing those data, and I'll present some of that coming up soon. But one of the things we did from the very beginning is we have a relationship with the coroner's service, so any unexpected death in the community, whether it's related to whether they have a test or not, is investigated for COVID. So we are confident that there's not a lot of people dying in the community from COVID that we don't know about, and we've done that analysis a few times. I will say that if anything, we overcall deaths from COVID, and we're looking at the deaths that we had here in the month of January, for example. There were 119 with a date of death in January, so I know there's been more deaths reported, but many, it sometimes takes time. For example, if somebody dies in the community and the coroner does an investigation and the test comes back positive, it may be several weeks before that is reported to us. So we had 119 people with a date of death in January, and not surprisingly, about a third of them, 41 of them, were people associated with an outbreak in long-term care. So in long-term care or acute care. And in that situation, it's We count anybody who dies within 30 days of their positive lab test in a long-term care outbreak. So, some people had very mild illness. COVID probably had nothing to do with the reason they died, or very little to do with the reason they died in some cases, and in other cases it was directly because of COVID. And if we look at people in the community, the 2/3, about 78 people who died in the month of January so far, who weren't associated with a care home, overwhelmingly, it's about 2/3 again are people over the age of 80. So again, it goes back to what we were talking about last week, with age being the number one reason, the number one risk factor for severe illness and death. We have had 4 people who are in their 50s or under, including a person in their 30s and a person in their 40s who died in the month of January, who did not, as far as we know, have any underlying illnesses. So it can affect some people more than others. As we get older, we're more likely to have other underlying illnesses. We call them things like heart disease or lung disease that put us at increased risk as well. And so all of those things compound your risk of having some more severe illness, and why vaccination becomes so much more important in older people as well. So that's a little bit of a summary. I am quite confident that we're not missing at least a lot of cases of people who have died related to COVID in the community.
Derek, do you have a follow-up?
Yes. Looking at the data that you released of status by vaccination, in the unvaccinated people who are contracting COVID-19 and dying, it was considerably large number of people over 70 sort of represented in that group. What new strategies are you looking at to try and reach that over 70 crowd to get vaccination, considering what you've learned from this?
Yeah, it is, as you know, age is that most important risk factor, but even younger people who are not yet protected with any vaccine also are more likely to end up in hospital or have severe illness or die from COVID, from all of the various strains, even with Omicron. So it is the same thing that we're doing. We've been trying to go even door to door in many cases, but community to community, working with community leaders, getting that message out to people where they might hear it. It goes back to the same things that we've seen all along, that there's one of the things is confidence in the vaccine, and there's some people that don't have that or don't believe that they need a vaccine, which is, unfortunate. And there's a small group of people that we probably, and the other part is confidence in safety, and we have more vaccines coming of different types that may help for some people. Part of it's complacency. People don't feel that it would affect them, that they're fine, that they don't need it. And so that's something we try and address by putting out the information around who is most likely at risk. And then convenience. So making it easy for somebody to get that vaccine. And anybody of any age who has made that important decision to get your first dose, you can walk into any clinic, any pharmacy that has vaccine anywhere in the province and get your vaccine now. Think about it today. It's going to make a difference in getting through this next few weeks, but it's going to make a difference for how we're going to be able to live with this virus and whatever happens next, too.
Over to Minister Dix.
Just to say, the over 70 category, and one of the differences between that category and younger children is that there's actually very little regional difference, Derek. There's a very high level of immunization over 70 in the Northern Health Authority and the Interior Health Authority, in all of our health authorities across BC. I think it's close to 90% in the Northern Health Authority. I think it's about 88, 89 there, and obviously province-wide it's 93%, which is a very high level of vaccination. 93% of people over 70 have got their first dose, 91% plus have their second dose, and of those 91%, about 85, 86% of those have got their third dose. And so what I'd say today to those people, first of all, the 45,000 people who've received invitations to book who are over 70 for their booster dose, received an invitation to book. That group of people has already received 2 doses, so they are by definition interested in the vaccine. Now is the time to get that additional protection. And if you need any more evidence than was provided by Dr. Henry last Friday, I think I'm sure there will be people, including your family doctor, including pharmacists, including people in the community, who can provide that to you. With respect to the small group of people over 70 and over 60 who have not received their first dose, we just have to continue to make the effort to let them know that anytime someone in that category wants to be vaccinated, at our hundreds of locations across British Columbia, of our many locations, the pharmacies are giving booster doses, but hundreds of locations across BC, they can get vaccinated today. If you're in that risk category, and there are some, and we just have to continue to drive that. We saw the impact of the Delta variant for months and months and months on unvaccinated people, how they had to be flown, in many cases, hundreds and hundreds of miles from their home to get critical care. In many cases, passing away, right? And so people need to get vaccinated, first and second dose. We just got to continue to tell them that it's available to them, that millions and millions of people, more than 10 million doses have been administered in BC so far. That across the country, significantly more than that. I think the number is more than 80 million across the country, across the world, in the billions. These are some of the safest vaccines we have, and we're here ready for you if today is the best day to choose to get vaccinated.
We have time for one more question. We'll go to Belle Puri, CBC.
Hi there, in English and in French, please. Dr. Henry, we're wondering about rules for non-church choirs in BC under the current guidelines. If you could clarify, please, if such choirs can rehearse in person right now, like if they have all the safety protocols, vaccination, masking, distancing, would such a rehearsal be allowed under the current public health order?
Yeah, there's no restrictions on choirs at the moment. There's the COVID safety plans that are required, but no, we haven't made any distinctions between singing groups in any setting. But obviously there's space, and we have guidelines about how to do it safely. Mask wearing.
Over to Minister Dix.
Il n'y a pas actuellement de différence entre les groupes maintenant, il n'y a pas de règlement en place pour cela, mais il faut faire attention, n'est-ce pas, d'utiliser des masques, bien entendu, et de suivre un plan de protection pour des gens, et ça c'est essentiel, et c'est ce qu'on doit faire maintenant.
Belle, do you have a follow-up?
Yes, please. The sub-variant of Omicron, is it in BC? And if so, what does that mean in terms of the province's response to the pandemic? And English and French, please.
Yeah, so we have had a few cases of the S4.2, I think it is. I think our first detection was about 2 weeks ago. Very small number, so it's not a significant difference right now, and there's still a whole lot we don't know. We have seen in the UK particularly, where they've seen it in pockets, that there is probably increased transmissibility, but whether that translates into any other parameters that are different, there hasn't been enough of it, certainly not here and not in Canada, to really see any impact. We're not seeing it we've been following my lab team has been following it really carefully, and we're not seeing it taking over from Omicron, as we saw Omicron take over from Delta, for example. So it is, I think, very similar to what we saw here, where you get regional differences in variants. If we look back at Delta, for example, we had regional ones that were here in Western Canada, 25 and 27, that were different from other places. And that just is because the virus mutates a little bit in different areas geographically when it's spreading that rapidly. So yet to know really what the overall impact is going to be, or if any.